I think certainly there's a couple of interesting studies, some of which are updates on existing studies, but really kind of reinforcing where things are heading in terms of myeloma treatment. So the first was a subgroup analysis from the COLUMBA study. So COLUMBA was an analysis of subcutaneous daratumumab versus intravenous daratumumab. And that data has already been presented previously, looking at the non-inferiority. But the key thing about subcutaneous daratumumab is it's a fixed dose, whereas intravenous daratumumab is based on a dosing per kilogram of body weight. And this particular subgroup analysis of over 500 patients was aimed to look at what the impact was of body weight on outcomes. And in essence, it showed that using a fixed dose did not seem to impact on outcomes. In other words, it doesn't matter too much whether your weight is less than 65 kilos or above 85 kilos. The outcomes were broadly comparable across the whole patient range. And using that information, therefore, it's possible for us to, with confidence, move across to using subcutaneous daratumumab either as monotherapy, where we're currently able to use it as fourth line, or more commonly now where we're using it as second line in the DVD regimen. And we very recently had access to subcutaneous daratumumab because of COVID, and that's been one of a number of, as it were, positive outcomes relating to COVID, that we've been able to actually switch treatments for patients. And so already, in our practice in Southampton, we started to move over to subcut daratumumab and reduce the infusion time from even rapid daratumumab, which is 90 minutes, down to 5 minutes. And that makes a massive difference from a patient experience perspective, but also, and importantly, makes a difference in terms of infection risk by reducing the amount of time that someone is physically in the hospital. And in the fullness of time, it may well enable home delivery of treatments as well. And again, that is a massive benefit, both from a quality of life perspective, but also, again, from an infection perspective, if patients don't have to be coming up to hospital every single week. So I think it's really, really crucial data that supports the shift from intravenous to subcutaneous daratumumab. Then there's also data, which is updated data, also daratumumab data actually, from the POLLUX study. So the POLLUX study was a comparison of daratumumab with lenalidomide and dexamethasone versus lenalidomide and dexamethasone in relapsed myeloma. And this was essentially an extended analysis with longer term median follow-up. I think what's most interesting about this study is the really impressive hazard ratio and the really impressive improvement in progression-free survival using a monoclonal antibody triplet that is combined with an IMiD, in this case with lenalidomide, compared with what we're currently using, where monoclonal antibodies are combined with a protein inhibitor with bortezomib. And we are in the situation we're in, where we're able to use DVD, which is a really good option for us. It will be really good, if not even better, if we were able to combine with a potent IMiD, because actually we're not just combining different drugs because we can, but actually if you combine a monoclonal antibody with an IMiD, you're actually benefiting from the immunostimulatory effect of having an IMiD that works alongside a monoclonal antibody. So there's an even stronger biological rationale to combine those drugs than there is potentially using a proteasome inhibitor backbone. So unfortunately, daratumumab, lenalidomide, and dexamethasone is not currently approved from a funding perspective, but I'm hopeful that we may well see that change in the years ahead. And I wouldn't be surprised if daratumumab Lendex becomes more of a standard of care in the fullness of time.